In fact, I'm interested, this morning I'm going to be charged with talking about ablation. I've had the honor of addressing the group a couple years ago in ablation and a couple of years before that. This is my third time back on the podium. Every year I'm in the minority in terms of the preferred treatment, but I guess I keep on coming back as the punching bag for ablation. So perhaps I'll share with you a little bit more data, and I think the percentage every year is getting a little bit more in terms of people perhaps considering ablation for the case that Dr. Uzo presented. So no doubt, partial nephrectomy is the ideal approach for the ideal patient for all the reasons we already heard from Dr. Russo. And what I would only advocate on this slide is that we cannot ignore for the patient who may otherwise do well with active surveillance, the fact that surgery has significant morbidity and recovery associated with it. And unless you're doing biopsy, which we may be able to talk about a little bit more in the discussion, if you're going into surgery without a biopsy, there's no doubt we're going to be doing perhaps morbid surgery for potentially benign disease. Similarly, as we heard about the criticism about ablation for perhaps benign disease. So, and I would like to, especially for the case in point today of a 76-year-old gentleman that perhaps surgery is overkill, and an alternative could be tumor ablation, whether it be laparoscopic or percutaneous. Cryotherapy, it's certainly cold in here this morning, or radiofrequency, it would warm up the room. But either way. Now, I've shown this slide every time I talk about this topic, and it really hasn't changed. Ablation is nephron sparing. We are dealing on the biology with slow-growing tumors with low aggressive potential anyway, so this may be a good compromise in terms of morbidity. It has lower morbidity than traditional surgery. Any of you who have had patients who've had this done can attest that this is much less morbid with fewer complications than partial nephrectomy. And if it's done as a percutaneous treatment, it is clearly an outpatient procedure under sedation. And surgery cannot compete with that. And last but not least, these tumors are incidentally discovered on imaging, and it's not unrealistic to be able to follow these patients with the radiographic imaging after treatment. It's not a weakness of the treatment. It's, in fact, I would consider it we're fortunate with kidney tumors and kidney cancers that we can follow our treatments radiographically. Now, we'll hear about active surveillance, and I certainly, I think in the case that we presented today, active surveillance would be a very good approach for the patient. But I am a little bit worried based on Rob's recent paper about compliance. Yes, he showed you that slide and about how those patients did over a median follow-up of 2 years. About three-quarters had some growth, but it's minimal growth in these tumors. What I found the most concerning in that paper is that 40% drop out of active surveillance over 2 years, not a lifetime, not 10 years, not 5 years. Over 2 years, 40% dropped out with a median follow-up of about 2 years. And the most common reason was for patient preference. And the second reason was interval growth. So the bottom line, as Rob suggested, anxiety in the active surveillance is a real problem for our patients. And even the patient probably presented today. So active surveillance may have a lifetime of its own before the patients drop out in about 40% of the group. Similarly, if you tell the patients that there's metastatic progression rate of about 1.3%, that is, in some patients' minds, a big concern. And keep in mind that that was 1% progression rate at 2-year median follow-up. What about 4 years? What about 6 years? What about 10 years? We're committing a patient to long-term surveillance without a long-term metastatic progression rate. And finally, if you don't have biopsy on these patients' data, then 70% of these presumably are renal clear cell carcinoma. Those are the ones that progressed. So the math actually works out to about 2%. Not much more difference, but 2% metastatic progression rate, the way I read Rob's paper, at 2 years. So there is some risk with active surveillance. So if we're going to propose a treatment as an alternative to surveillance or surgery, it certainly has to have low morbidity, it has to have oncologic efficacy, it has to be maximum nephrons preserving, as Dr. Russo already emphasized, and lastly, I think it needs to be cost effective. And we don't have time to go through extensive data or the AUA guidelines, but in terms of morbidity, I think we're all in agreement that a percutaneous ablation is an outpatient procedure with the lowest morbidity. A laparoscopic ablation, patients routinely stay in the hospital only 1 day. And when you talk about the major risks of partial nephrectomy being hemorrhage, there's no doubt that the tumor ablation procedures, particularly radiofrequency in this case, have significantly, because it's a hemostatic procedure, energy-based technology, it's going to have significantly less risk of hemorrhage. And this patient, for example, was on Coumadin, I saw. And finally, because we're not excising the tumor, the risk of urine leak intuitively would be very, very low, if not rare. As far as oncologic efficacy, well, there is certainly a lead time bias towards partial nephrectomy. We have not been doing ablations. When I was here 4 years ago, I had even less data to share with you, but we're getting there in terms of ablation. The most recent experience from Cleveland Clinic is a series granted. This is not a table with review of literature, but in experienced hands, cryoablation, we're seeing 5-year data that I think is comparable to surgery and 10-year actuarial data that is similarly comparable to surgery for T1A tumors. Percutaneous ablation, not as well published, not as well developed with cryoablation, but there is evidence to suggest that we're getting reasonable tumor control in terms of disease-free survival. Now, radiofrequency, the same thing. Radiofrequency gets a knock very commonly in the literature, but in experienced hands, the results can be as good as cryotherapy. And that is, here's the Hopkins group at 5 years. I think what's most important here that they didn't see any patients progress with metastatic or disease-free survival at 5 years. At Southwestern, where I'm from, we just got this paper now in press. It's a boring curve because at 5 years, we see no significant patient drop-off in terms of cancer-specific survival, and our overall survival is 85%. So we're seeing oncologic results that are acceptable, at least they're not disappointing or concerning. Now, albeit there is only one article that I know in the literature that directly compares to partial nephrectomy. It's a weak article authored by myself, I admit it, but it's the only thing we have. And keep in mind, there is no randomized prospective trial of partial nephrectomy versus radical nephrectomy versus simple nephrectomy. And so to expect a randomized clinical trial of an ablation versus surgery is a little bit hopeful, to say the least. But so here we are in a case-match series. I think we'll see this with cryo as well. There's no doubt in my mind. We're seeing comparable results at 3 years in this experience. And if you're going back to the Cleveland experience, I think we would see the same thing in cryoablation. Now, what about preservation? Dr. Uzzo mentioned this a few minutes ago. This is a paper by Ganesh Raj, Steve Lucas, and I was a co-author as well at Southwestern. This is for radiofrequency ablation. There's no doubt, again, cryoablation, I think, would mimic these results. And this is the risk of developing chronic kidney disease stage 3 and stage 4. And there's no doubt in terms of stage 4, GFR less than 45, RFA and partial nephrectomy are comparable in preventing that development in our patients. But I can tell you, in Dallas at least, it seems like the ablation procedures are even more renoprotective than partial nephrectomy, which is done under cold ischemia in this series here. So at least in mild chronic kidney disease, it may suggest, at least in our experience, that RFA may give us a little bit of an advantage. And looking at patients with solitary kidneys only, matching RFA with open partial nephrectomy, and again, I think this is the same for cryoablation, albeit the tumor size was 3 millimeters larger, but nevertheless, in terms of loss of renal function, what we're seeing is that from baseline GFR, that the RFA group might do certainly as good, if not better, in terms of preserving renal function in a solitary kidney than partial nephrectomy. And finally, cost. There is no doubt when you do an outpatient percutaneous ablation, you're going to win in terms of cost for our patients. And so when we're talking about a treatment